Thanks so much for including me in this important conference. My topic today will be living well during and after male breast cancer treatment. And as mentioned, I am a breast oncologist, breast medical oncologist at Mayo Clinic in Rochester, Minnesota, and I do focus some of my research on male breast cancer, and certainly am very committed to this as an important area of additional research, and very happy to talk about this with you all today. Hopefully we'll have a little bit of time for discussion at the end of my talk. I'm planning to touch on a bit of epidemiology, meaning stats related to male breast cancer, review a bit about common clinical and biological features, prognostic factors, treatments. I know Dr. Leon will be talking more about endocrine therapy, but just a bit about toxicity and survivorship recommendations, and then a few ideas for future research. Dr. Fitzhugh Mullen was a physician and cancer survivor who published in the New England Journal in 1985 this very important quote: "The challenge in overcoming cancer is not only to find therapies that will prevent or arrest the disease quickly, but also to map the middle ground of survivorship and minimize medical and social hazards." And I come back to this frequently when I'm considering my work in cancer survivorship. There are about 2,000 cases of male breast cancer diagnosed every year in the United States, and we know that incidence of male breast cancer is rising, but it still only accounts for about for less than 1% of all breast cancers in the U.S. So 99% are occurring in women and 1% in men. In other parts of the world, male breast cancer comprises a larger proportion of the breast cancer. So in specific countries in Africa, the rates are even in Zambia said to be greater than 10%. And this probably has something to do with some of the endemic infections that cause liver dysfunction and therefore dysregulate hormonal balance. It may also have something to do with the fact that there are lower rates of mammographic screening for women, and therefore some of those female breast cancers may be going undiagnosed. In male breast cancer, most male breast cancers, as you probably know, are being found by men themselves as a mass in the breast. It's usually a non-tender breast, so it's a mass. It doesn't hurt, but it's hard, and oftentimes these masses have grown to an average size of 3 or 3.5 centimeters at the time of diagnosis. And often they're near the nipple, so they can cause nipple retraction, nipple discharge, or a nipple eczema, meaning skin changes of the nipple. Lymph nodes are often enlarged at the time of diagnosis, and the average age of diagnosis in men is about a decade older than in women. And this may be in part because female breast cancers are often diagnosed by routine mammography, and so may be found before they're actually large enough to be palpable. In situ disease means a breast cancer that is not yet invasive. So there are two types of in situ disease: lobular carcinoma in situ and ductal carcinoma in situ. And this is pretty rare for male breast cancer, probably in part because we aren't finding these with mammography, but really only 5 to 10% of all male breast cancers are found before they become invasive. So 90 to 95% of male breast cancers are already invasive, meaning that they've gone, that they do have the possibility of spreading elsewhere in the body, and are not definitely just in the breast itself. Lobular carcinoma in situ, that's very, very rare in men because of the way that the lobules basically refer to the part of the breast that creates breast milk, and there really are not terminal lobules, which are where lobular carcinoma in situ usually comes from in the male breast. But ductal carcinoma in situ, we do sometimes see, and ducts are within the breast, really what in a female breast would bring the breast milk to the nipple, but in a male breast, those ducts are still present, and therefore we can sometimes see ductal carcinoma in situ. We talk about grade of in situ carcinomas, meaning how close they look to an invasive cancer. And we do, happily, when we do see ductal carcinoma in situ in men, those are more likely a low-grade ductal carcinoma in situ than it is when we find these in women. I want to talk a little bit about one of my patients. This was one of the first men I ever saw with male breast cancer back when I was a fellow. This was now more than 15 years ago. He was a 67-year-old man whose daughter had already was known to have a deleterious genetic mutation in the BRCA2 gene. And so he was kind of keeping an eye on his own breast tissue when he found a hard mass in his left breast. He went on to have a biopsy and then a mastectomy with a lymph node dissection that found, at that time, we were not doing, this was now, as I said, more than 15 years ago. Today, he probably would have had a sentinel lymph node biopsy, but at that time he had a lymph node dissection. He did not have any lymph node involvement, happily, but he did have a 2.7 centimeter high-grade cancer, invasive ductal carcinoma. And like most male breast cancers, this tumor was found to be hormonally sensitive. So we know that more than 90% of male breast cancers, which is a higher percent than we find in women, are hormonally sensitive. So that means estrogen receptor positive, which we often term ER, the estrogen receptor. His was also progesterone receptor or PR positive. And we also look at a protein called HER2/neu, and this was negative in his tumor. So HER2/neu protein, when it is overexpressed on a breast cancer, suggests a more aggressive tumor biology and needs to be treated with a specific class of antibodies and usually chemotherapy. In this case, his tumor did not overexpress the HER2/neu protein, but it still was high grade. And it was not teeny tiny. It was kind of an average size, 2.7 centimeter tumor. Well, there have been a variety of studies that have compared male breast cancers to female breast cancers. And in multiple studies, including the one I'm showing you here, we've seen that there are higher rates of stage 2 and 3 cancers in men than in women. As I said, that's probably in large part because we don't actually find these until either a man or a physician finds the mass, and therefore we're not having as many low stage cancers that are not yet palpable in men as we are in women. And we all do have a higher rate of lymph node positivity. As you see here in this study, the rate of lymph node positivity, meaning cancer having spread to lymph nodes under the arm or in the breast region, was 28.2% in the female breast cancers and 41.8% in male breast cancers. And that's important because it does mean that the risk of recurrence is higher when cancer has spread to lymph nodes. But happily, prognostic-wise, if you match actually, and you take a male breast cancer that happens in a man, let's say a 67-year-old man compared to a 67-year-old woman with exactly the same tumor size and lymph node status, men actually do a little bit better than women do in terms of prognosis for the exact same, or at least what looks like a very similar tumor stage and biology. And also good news is that for both sexes, we've seen improvements in survival over recent years, improvements in cure rates. And that's probably because our treatments have improved. You know, we do have a lot of great advances in breast cancer care over the decades. Even over the last few years, we've seen the development and introduction of new medications that can help us cure and control breast cancer better. I do want to note that men who are diagnosed at a younger age and those without spread of cancer to the lymph nodes do seem to have the best prognoses. In one study recently looking at stage 1 breast cancer, which generally means breast cancer that hasn't spread to lymph nodes, where there was a median age of 66 years in men, which is about what we've seen in most studies of male breast cancer, there was better survival associated not only with younger age, but also with low tumor grade, with having received surgery. There are some people who don't receive surgery for their breast cancers. With lymph node evaluation, we know it is really important to assess the lymph nodes in most cases. And interestingly, men who were married had better survival than men who were not married. There were no survival differences between breast conservation, meaning men who had lumpectomy, just the tumor removed, or men who had the entire breast removed did equally well. And it didn't seem to matter how many lymph nodes were removed at the time of the surgery. Another study that was focusing specifically on men who were diagnosed with breast cancer at a very young age, between ages 15 and 39, had actually little bit higher percentage of these men had these in situ or non-invasive cancers than we've seen in other studies. So 18% had the not only non-invasive cancer. 82% did have invasive cancers. That's what we usually see. And here again, interestingly, when they looked at kind of putting in all different variables that might affect outcomes into their models, trying to discern who is likely to do very well after male breast cancer, they found that age over 25 years was associated with better outcomes in this very young cohort. And also, again, having lymph nodes evaluated. So the reason it's important to look at lymph nodes is because it does affect what kinds of treatments we recommend. It can affect whether radiation might be warranted. It can affect whether chemotherapy might be warranted to know the full extent of the cancer. Unfortunately, treatment of breast cancer in men is really mostly extrapolated from data we have in women. As I'm sure you all are aware, we really have a paucity of research that's really specifically focused on male breast cancer, and clinical trials have been really lacking here. So when we do extrapolate from data in women, we don't know for sure that things like Oncotype DX, which is a tool we use to understand chemotherapy sensitivity that's been validated in women, we don't know for sure that the scores mean exactly the same thing in men. There was one treatment trial that tried to only enroll men with breast cancer. This was a study of an anti-estrogen treatment called anastrozole with a medication called goserelin, which is what we call a gonadotropin releasing hormone agonist, meaning this was trying to get hormone levels really low in men who had advanced metastatic hormonally sensitive breast cancer. And it was going to be, I think, a very important study because it was going to look at over time, how did hormone levels change on that treatment and drug metabolism in men. But sadly, over a 2-year accrual period, now this was at this point many years ago, zero subjects patients, not subjects, 0 patients enrolled. And so the study closed without really being able to help us with understanding this. And I know that Dr. Leon will be talking about his very important trial that is about to open. And we're very excited to try again with a treatment trial in male breast cancer. I mentioned surgery, and most men with breast cancer do choose to have a modified radical mastectomy, meaning that the entire breast is removed. Some historically have done even more aggressive surgery. That's, I think, less. I have not had many of my male breast cancer patients choosing radical mastectomy, which is removing kind of more of the muscle and other areas that can cause more side effects. Lumpectomy is the minority of men, although I would say that's becoming a little bit more common in recent years that men are choosing lumpectomy. Radiation, again, we don't have great data to guide us in who needs radiation for male breast cancer, but we think that the indications for radiation are similar to in women. So usually that means things like having, after a lumpectomy, most men will be recommended to receive radiation. Even after mastectomy, radiation is sometimes needed to reduce risk of local recurrence, particularly if there are lymph nodes involved or the cancer is very large. Anti-estrogen treatment or endocrine therapy is very important, we think, for male breast cancer because it is so common that breast cancers that develop in men are expressing that estrogen receptor and that progesterone receptor. So as I said, more than 90% of men are going to have an estrogen and progesterone receptor positive cancer, and or I should say, and therefore we think that reducing the stimulation to any either reducing the amount of estrogen or actually blocking the estrogen receptor with a medication like tamoxifen is likely an important component of treatment. Now, again, we don't have randomized trials like we do in women, but we have seen some very encouraging results, including from a study of 135 men with a 14-year follow-up, where there was improved survival in men who had taken anti-estrogen treatment. And tamoxifen, the blocker of the estrogen receptor, is a pill that's really our gold standard in this setting. We sometimes consider other types of anti-estrogens. If there's a contraindication to tamoxifen, or Dr. Leon will tell you about his study that's going to really help us understand, are there things we can do that might be even more effective than tamoxifen, including these gonadotropin releasing hormone agonist shots that get the hormone levels even lower. Tamoxifen doesn't actually reduce hormone levels. It really just blocks the estrogen receptor. But things like the gonadotropin releasing hormone agonist, possibly with aromatase inhibitors, can reduce the hormone levels themselves. There are also medications like fulvestrant, which is an injectable medicine that's kind of a cousin of tamoxifens that affects the estrogen receptor, and we sometimes use particularly for men who have advanced or metastatic breast cancer. And we also have some other case reports, meaning a few patients who have seemed to respond to other types of hormone-related medications, particularly for metastatic disease. And we clearly need more research in this area to clarify what the best treatments are for men with breast cancer. A note about chemotherapy. Chemotherapy is obviously not something that we embark upon lightly for any patient because there are significant side effects from chemotherapy. Those of you who have received it know that chemotherapy can come with some risks of things like heart, depending on the drugs themselves, but there can be risks to the heart. There can be risks to there can be risks of nausea and vomiting that are unpleasant. There can be long-term risks of things like leukemia. So certainly we only recommend chemotherapy, whether to a man or a woman. We only recommend chemotherapy when we think it will be substantially beneficial to reduce risk of recurrence or control the cancer. So we know that in men, we see more chemotherapy given to those who are younger, and that's true in women as well, to those who have higher tumor grade, which when a cancer has a higher tumor grade, it really means that the cells seem to be dividing faster and therefore would be more sensitive to chemotherapy. And so that makes sense. And it also makes sense that there's more chemotherapy given to men who have lymph nodes where there's been cancer spread to the regional lymph nodes, because there the risk of recurrence is higher, as I mentioned, and therefore you would get more benefit from any type of treatment that might wipe out cancer cells. I'm again here, we don't have randomized trial data to say what chemotherapy would be the best in men or to definitively tell us about chemotherapy efficacy, although we do have some retrospective studies looking back at men who did or did not get chemotherapy. We think in general, if you take all men with breast cancer and you compare it to all women with breast cancer, there's probably less benefit from chemotherapy in men just because of the more hormonally sensitive breast cancers. We know that the more hormonally sensitive your breast cancer is, at least in women, the less benefit you tend to get from chemotherapy and the more you get from anti-estrogen medicine. And so anti-estrogen medicine is probably the most important component of treatment for a lot of men other than surgery. So coming back to my patient, he actually did go on to receive chemotherapy. He received 2 drugs, doxorubicin and cyclophosphamide. So he received 4 doses of that and then 5 years of tamoxifen. He did go have testing for genetic mutation, and I know you'll hear more about the importance of genetics in male breast cancer later today, so I won't talk in too much detail about that, but he was found to carry that same BRCA2 mutation that his daughter had known that she had, and then they did go to make sure that their other family members were tested. Her siblings were then tested, and important to note that when he started tamoxifen, he had some pretty severe hot flashes that were really impairing his quality of life. We ended up treating him with venlafaxine, which did seem to help. This is an antidepressant for which there's some data that hot flashes may be managed with venlafaxine and other similar antidepressant medications. After 5 years, he had saw me every 6 months for that 5 years of treatment on tamoxifen, but then he transitioned his care back to his primary care provider after that time. So I want to talk just a little bit about survivorship care, because this is another one of my passions. And really, what do we mean by survivorship care? When I'm talking about survivorship care, I'm really talking about some medical things like physical exams to assure that there's no evidence of recurrence, treatment of complications of cancer therapy, such as venlafaxine for hot flashes, counseling about lifestyle. So things like, are you exercising? Are you drinking too much alcohol? Those kinds of things. And then also non-cancer related medical things. So of course, we're all possibly susceptible to a variety of different medical issues that have nothing to do with cancer. And so for me, part of when I'm providing survivorship care, I'm also thinking about, is a patient seeing primary care or getting other care for other types of problems like diabetes, high blood pressure, and other issues that could be important for overall health. And then there's also the psychosocial piece. Of course, there's a lot of distress that can be associated with the cancer diagnosis and also the cancer survivorship period. We engage our social workers to help patients manage this at all points in the cancer journey, because I don't think at all that the anxiety or depression that may be associated with cancer goes away as soon as chemotherapy ends. And part of what our social workers also do is try to help patients with the financial burdens of their cancer treatment. And part of what we do also is make sure that genetic counseling and testing has been offered to our patients. And really, to do this well, this really requires a lot of coordination of care between the oncology care team, primary care providers, and other providers. And so I mentioned some of the goals of survivorship care. And I also think it's important to talk about the fact that these anti-estrogen medicines require that you take them. If you're on an anti-estrogen pill, it can be hard to remember to take that every day for 5 years. And especially when there are other medications that you're trying to take to manage other medical conditions. And so part of what I talk about with my survivors is adherence to these medical therapies. We talk about research updates that might impact their care. And of course, I try to provide psychosocial and decision-making support. I mentioned the fact that survivorship care is very multidisciplinary. And so in addition to our primary care providers and medical oncologists, there's a really key role for our advanced practice providers like nurse practitioners, our nurses, our radiation oncologists, our surgical oncologists. I would take gynecologists off the list for men. This is a slide that applies across the board for survivorship care. But cardiologists, plastic surgeons, physical medicine and rehab is really important. And these folks can help if you're experiencing lymphedema, if you have fatigue or physical dysfunction, whether it's related to cancer or not. Our physical medicine and rehab specialists are really important parts of our survivorship team. Integrative medicine, we actually have a new integrative oncologist here who is providing a lot of great care for our patients related to the potential value of acupuncture, massage, and other integrative techniques. Psychologists and psychiatrists, social workers, dentists, ophthalmologists, orthopedists, dermatologists, and other specialists. And I'm really want to emphasize that this survivorship care cannot be done as well as, for many patients, survivorship care requires more than one specialty to do optimally. The National Comprehensive Cancer Network has put out a really nice survivorship guideline. It does have there are some materials that are directed to patients. What I'm showing you here is actually not directed to patients, but it's directed to providers and gives a nice summary of all of the recommended areas that they suggest that patients, regardless of cancer type, be asked about related to cancer survivorship. And these include cardiac health, anxiety, depression, trauma, and distress, cognitive function, fatigue, lymphedema, hormone-related symptoms, pain, sexual function, sleep, healthy lifestyle, immunizations and infections, and employment. And so these are, I show you this, not that these specific questions on this slide are necessary, but that these are areas that are important in cancer survivorship. And hopefully you have providers who can help you with any of these issues that you might be dealing with. We know that in male breast cancer, there is an increased risk compared to men in the general population after a breast cancer for having a new breast cancer on the other side. But happily, the risk of a new breast cancer in the other breast is still very, very low. And so the risk is still less than 2% that a breast cancer would be, that a new breast cancer would occur on the other side in a male breast cancer survivor. We do know that men who carry a genetic mutation, such as the BRCA2 mutation, do have a higher risk of not only a new breast cancer, but also other cancers like prostate cancer, pancreatic cancer, gallbladder, gastric, and melanoma. And so those are things that it would be important if you do know that you carry a genetic mutation um, that is associated with cancer. It's important to talk to your doctor about whether any additional screening would be needed for these other types of cancer. And it's, as I mentioned before, other medical issues like hypercholesterolemia, meaning high cholesterol, high blood pressure, and other cancers like colon cancer. I mean, we all need to be thinking about cancer screening, colonoscopy screening. Now, the recommendations are that we should be doing GI cancer screening starting at age 45, regardless of family history. So even if you have nobody in your family has ever had colon cancer, you should be talking to your primary care provider at least about whether you have completed your recommended colon cancer screening. Usually that means a colonoscopy at least every 10 years, although there are some other methods that are now available as well. Side effects of cancer therapy can be multiple. And so we know that lymphedema, or swelling of a limb related to removal of lymph nodes, is one very common side effect of breast cancer treatments, including surgery or radiation. We can also cause bone thinning, hot flashes, joint and muscle pain, trouble sleeping, nerve damage, infertility, and blood clots. And that's related to some of our systemic therapies, meaning either chemotherapies or pill anti-estrogen treatments. And both local treatments and our systemic treatments can cause problems with the heart, chronic pain, psychosocial distress, weight gain, fatigue, and even rarely a secondary cancer. And so these are all issues that may be important for you during cancer survivorship, and things that hopefully you can discuss with your clinician if you are having difficulties with. There have been a few studies that have looked specifically at the side effects of anti-estrogen treatment in men. This first one was conducted at Sloan Kettering in New York and found that 21% of a cohort of 24 men who were taking tamoxifen stopped taking that tamoxifen within a year of starting. And that was largely due to side effects. 29% of the men reported that they had had a decrease in their sex drive, 25% reported weight gain, 21% reported hot flashes and mood changes, 13% problems with sleep, and 4% blood clot. And so, these are really significant. And I think we need more research to understand how to help men manage these side effects so that they are able to stay on their recommended anti-estrogen treatments. Very similar findings of the study that was conducted in Canada, reviewing 59 men who had had either early stage or metastatic male breast cancer. 38 of the 59 had received tamoxifen, and half of those had at least one side effect documented in the chart. And again, it was about a quarter who stopped tamoxifen early due to side effects. 18% of men had hot flashes, 13% had decreased sex drive, weight gain, or poor energy, 8% had rash or erectile dysfunction. In another smaller group of men, 8 of the 59 men had received anastrozole. So this is one of these aromatase inhibitors that's kind of a less recommended alternative to tamoxifen. But amongst those men, 38% had at least one side effect documented. One of them had decreased sex drive, one had leg swelling, and one had depression. Letrozole, another even smaller group, only 5 men received letrozole, which is kind of a cousin of anastrozole. Again, 40% had at least one side effect documented, and this was swelling and hot flashes. And then the third and last study I wanted to tell you about, again, very similar findings. 64 men who were seen at MD Anderson in Texas who were receiving tamoxifen. And again, about half had one or more toxicities documented. There was weight gain in 22%, sexual dysfunction in 22%, and again, an early discontinuation of tamoxifen in 1 in 5. And this was due to a variety of the stopping tamoxifen early was due to a variety of different symptoms. Ocular, meaning eye symptoms, leg cramps, trouble with thinking, bone pain, sexual dysfunction, or blood clots. And so these are very, very common, at least based on these small studies. We don't have large studies to tell us across thousands of men what the incidence of these side effects is, but I think it's clear that we do need additional research to understand how best to manage these. A couple of practical tips, just while I'm on this topic, we do know, at least in women, that there are some things that can help with hot flash management. And I've certainly had some of my male patients tell me that these help them as well. Because hot flashes often occur at night and interrupt sleep, it can be helpful to keep the bedroom cool. During the day, to dress in layers and use a fan. Keeping the neck cool seems to be particularly important because that is a trigger zone for hot flashes. So whether that's with there are pillows that are actually have a cool kind of you can put water into them, and so at night they can keep your neck cool. Or you can also just use a wet washcloth. Other strategies that may reduce hot flashes based on data in women include weight loss, cognitive behavioral therapy, and that's kind of working with a social worker or a psychologist to reframe thinking around some of the physical symptoms, hypnosis, mindfulness, meditation, and then there are medications. I mentioned venlafaxine. There are also other antidepressants like citalopram and medications like gabapentin and oxybutynin, for which there are some data that hot flashes may respond to. One of my colleagues actually recently published this study of oxybutynin in women who had hot flashes. These women were having at least 28 hot flashes per week, and they were eligible. Some of them were taking anti-estrogen treatment for breast cancer, and they were randomized to 2 different doses of this medicine. This medicine was traditionally used for bladder concerns. On this study, 2 different doses of the oxybutynin and then 1 dose of placebo, which is basically a sugar pill. So patients were randomized to one of these 3 groups for 6 weeks of treatment after a baseline week without any medication. And here you see results from this study with the hot flash change in those who just took the sugar pill, the placebo, shown in red. There was some improvement in hot flashes even with that, but then with the 2 doses of oxybutynin shown in blue, you see much more significant reductions in hot flashes. And so this is very promising. And there actually is a study ongoing now of oxybutynin in men, but primarily that's men with prostate cancer through the Alliance for Clinical Trials in Oncology. Insomnia is also a very important concern in cancer survivors. As you know, hot flashes can interrupt sleep. We know that good sleep hygiene can be helpful. So obviously, many of us are very tempted to have our cell phones in the bedroom, to have, to be checking them in the middle of the night when we wake up. That certainly can be not very helpful for sleep hygiene. Cognitive behavioral therapy, again, may help with sleep, particularly if it's persisting despite adequate treatment of hot flashes. Keeping the room dark and quiet is, of course, also helpful for sleep. I want to talk a little bit about a pilot study of male breast cancer that we conducted more than 10 years ago now. This was an online survey of men who were between 0 and 10 years after diagnosis with breast cancer. They participated, maybe some of you participated, through one of these 3 websites that were geared toward male survivors. And we did have more than 40 men participating. Mean age was 64 years, and our participants were on average about 2 years after diagnosis. It was largely a relatively financially well-off group, with 52% reporting that they were very financially stable, and 62% having received chemotherapy. Genetic testing results, it's interesting because we really do recommend that all men with breast cancer be referred for genetic counseling based on the risk that there could be a BRCA mutation or other genetic mutation underlying that cancer. Only 74% of our respondents to this online survey reported that they had been referred for genetic counseling. Now, as I said, this was more than 10 years ago, so we hope these rates have improved in recent years. Only 60% had actually undergone the genetic testing, and 12% of those were found to carry a BRCA mutation. Fertility concerns, we also looked at this because As I mentioned, breast cancer treatment can impact fertility. The respondents to our survey, 24% of those men did not have any biological children. 5% did wish for future biological children. 7% had been told that their treatment could impact their fertility, and 2% had stored sperm prior to treatment. And so this is an area, obviously, not every man is going to be concerned or wishing future fertility, but it is an important area that we make sure that we're discussing with our patients, and hopefully we're offering fertility preservation to those who are interested. Chronic side effects of our treatments. I talked a little bit about the anti-estrogen treatments, but some men are receiving chemotherapy, as my patient did. And in this survey, as I said, more than half of the respondents had received chemotherapy. A significant proportion did report that they were having persistent problems with numbness and tingling related to the chemotherapies they'd received. 1 in 5 were having chest wall pain from their surgeries. Nearly 1 in 5 were having lymphedema, the swelling of a limb. One of the men, so 5%, reported, 2 of the men who responded reported a heart problem that they attributed to their breast cancer treatment. Just a word on cardiovascular disease, because this is a very important issue both in cancer survivorship and outside cancer survivorship. Some of our chemotherapies, including anthracyclines, like my patient received, do increase risk for heart failure. But most cardiovascular disease in cancer survivors are not necessarily related to any specific treatment for cancer, but are related to other medical problems like high blood pressure, high cholesterol, smoking, obesity, and/or diabetes. And so it's really important that cancer survivors be assessed for these conditions and counseled about risk factors, options for treatment, and healthy lifestyle. And just a word about lifestyle. The National Comprehensive Cancer Network that I mentioned earlier does provide some really quite detailed principles of exercise for cancer survivors. These are not specific to male breast cancer or even to breast cancer, but just across the board, these recommendations come from physical therapists and physical medicine and rehab doctors who have really thoughtfully put together some recommendations for aiming for both aerobic exercise, stretching, as well as muscle building activities across, across all cancer survivors to hopefully maintain and improve physical condition and energy and strength. And balance. Balance is also really important. None of us want to be falling and breaking a hip because of balance issues that can develop, in any of us with age. So I would point you to anyone is able to actually access the NCCN website. All you need is an email address. So if you'd like to spend some more time looking at these materials, I'd encourage you to go to www.nccn.org for additional information about these recommendations. I want to talk just briefly about the International Retrospective Male Breast Cancer Registry. This included more than nearly 1,500 men who had been diagnosed with breast cancer across the world. And a couple of the key findings, Fatima Cardoso led this out of Europe. A couple of her key findings were that outcomes did improve over the 20 years that this study looked at male breast cancer diagnoses. We did happily see improvements in outcomes over time. We saw better outcomes for those with strongly hormone receptor positive tumors. And interestingly, in this study, there didn't seem to be any impact of tumor subtype grade. Ki-67 is another indicator of how fast the cells look like they're dividing. HER2/neu, none of that seemed to be prognostic in this large retrospective study. But again, it did go back 20 years, so not necessarily applicable to today's therapies. The American Society of Clinical Oncology put out some imaging recommendations in a recent male breast cancer survivorship guideline that they published. And they did recommend that men who have a lumpectomy should have mammograms of of the breast that underwent the lumpectomy, so the side that had cancer. They do recommend annual mammograms for men who have a predisposing genetic mutation, such as the BRCA2 mutation that my patient had. The ASCO organization recommends annual mammograms of that breast as well. And they don't recommend any routine breast MRIs in surveillance for men with breast cancer. Other important care guidelines that were included in that recent publication by ASCO, focused specifically on male breast cancer, included that the gold standard for anti-estrogen treatment currently for men is tamoxifen for at least 5 years, as long as the tumor was estrogen receptor positive, which most are. ASCO recommends against bone strengthening agents for prevention of recurrence. So these, in women, in postmenopausal women, we know that using bone strengthening agents like zoledronic acid can help prevent recurrence. But but ASCO does not recommend this in men for that indication. For men who have osteoporosis, who already have some bone thinning, meaning then these medications could be used. ASCO recommends anti-estrogen treatment as first line for most men who have metastatic cancers, and also strongly recommends genetic counseling and genetic testing for men with breast cancer, as other guidelines have. So remaining questions. We really are excited that Dr. Leone will be launching this study to help us understand what really is the best endocrine therapy for men. Is it tamoxifen, or is there something better? And then, as I mentioned, we really do need research to help us figure out how to improve symptoms in male survivors. We'd like to understand about whether chemotherapy benefits are the same in men as women. And also, do our data on the importance of exercise, on the importance of minimizing alcohol, on reducing obesity, and on managing lymphedema from studies in women apply to men. So I mentioned Dr. Leone's very important study. There's also ongoing work from a prospective male breast cancer registry, which has stopped enrolling, but for which data will still be, we hope, coming out over the years to come, led by Dr. Cardoso and Dr. Giordano. And so I'm happy that the USA was able to be part of that, but we also had great collaborators in Europe and South America in this work. So I'll stop and take questions.
Well, thank you very much. That was a wonderful presentation. I do see a couple questions in the chat. One of them is a 50-year-old man with ductal carcinoma in situ with clear sentinel and non-sentinel nodes and a mastectomy. Would you prescribe tamoxifen or something else? And they are ER/PR positive.
So if there's only ductal carcinoma in situ and the man has had a mastectomy, I generally do not recommend tamoxifen. Now, again, we're in a data-free zone, but extrapolating from our care of women, if there's only in situ carcinoma and the breast has been removed, then there's generally not a risk that that cancer would spread anywhere else in the body. And so we don't generally recommend any type of systemic therapy. The surgery itself is thought to be the curative treatment.
Okay. One other one. In a male survivor with low testosterone, ER/PR positive, would you recommend a testosterone gel?
So it's interesting. My colleague, Dr. Laprinzi, did look at testosterone gel for management of hot flashes and did not find that to be an effective treatment. For a man who has a hormone receptor positive cancer, I do worry somewhat about exogenous hormones. I would say that this is a decision that would need to be made in collaboration with primary care and others who are more experienced with hormone repletion. As a breast oncologist, I'm usually working on trying to get the hormone levels as low as I can to prevent recurrence.
Okay. Is there a screening specific for pancreatic cancer?
There are imaging tests that can be done for pancreatic cancer. That would need to be, so genetic counselors can provide kind of guidelines about when that would be appropriate. Basically MRI is the main, to my knowledge, the main screening test. So it's not something that you would want to do on a monthly basis, but it is something that some patients do undergo for screening depending on the specific genetic mutation that they carry.
I asked that because I am leaving for Boston, where my wife's uncle, who was pretty healthy, 77, had some stomach pains and 3 3 weeks later passed away from that. And my wife's a radiation therapist, and I have 2 good friends who are oncologists. Pancreatic's a tough cancer. So, I mean, I have stomach pains, but I mean, every once in a while, but I don't want to be neurotic about it, but there's nothing but getting an image, huh? That's a tough one.
To my knowledge, there's nothing other than MRI, but that's certainly something you should talk. If you've had genetic testing, you could discuss it with the genetic counselor. But yeah, imaging is usually the way that's what I'm aware of.
Thank you.
Okay, I have one more here. What does surveillance for recurrence consist of?
So in breast cancer in general, if someone has had a breast cancer that has been curatively treated with surgery, possibly with anti-estrogen treatments and or chemotherapy, sometimes radiation, after the chemotherapy, radiation, and surgery piece is completed, we usually see people back intermittently over the period of their anti-estrogen treatment. And that is primarily for 2 reasons. One is physical exam. That is our primary way of surveilling, but also to talk about what symptoms somebody's having. So if they are having, let's say, a new back pain or a new problem that is otherwise worrisome that perhaps the cancer is back, then we would recommend imaging and sometimes blood work. If somebody's feeling perfectly well, then there is no recommended routine imaging other than, as I mentioned, the recommendations about some people having breast tissue imaging, mammograms generally. There's no recommendation for doing scans of the rest of the body if somebody's feeling perfectly well.
Okay, thank you. Any other questions? That's all I see in the chat right now.
Well, thanks so much for these great questions, and it's nice to meet
Thank
you all.
you.